Good evening, everyone. I'd like to thank the college for giving me this opportunity. Right. So I'll be talking about the approach to conjunctival pigmented lesions. So conjunctival pigmented lesions, I'm sure all of you have come across, and they present with a variety of clinical pictures, and sometimes diagnosing the actual condition may be a bit of a challenge. So if we consider the types of conjunctival pigmented lesions, mainly they include two categories. One is the ocular surface tumors arising due to the proliferation of neuroectodermal cells or melanocytes of the conjunctiva. So these are proliferative lesions. They include the conjunctival nevi and the conjunctival malignant melanoma. The next type is the conjunctival melanosis. So this is not actually a proliferation. It's mainly caused by excessive pigmentation, and it manifests without an elevated mass. So this includes the complexion associated melanosis and the primary acquired melanosis and the secondary acquired melanosis. So we'll discuss about these different types of lesions in the coming slides. So if we take a look at this lesion here, so by the appearance, just take a look and see whether you can identify whether it's a nevus, whether it's a complexion-associated melanosis, primary acquired melanosis, or a melanoma. So how do we differentiate? So to differentiate, the useful tips, one is the history and the other one is the clinical features of the lesion. In the history, what is important is the age of onset of the lesion. If it's a lesion which has been there for a long time, since childhood for example, so then the risk of malignancy is quite less. Then the race, if it occurs in a patient who is a white person, then there is high suspicion of a malignant lesion. Then if the patient has a past history or a family history of skin cancer like melanoma, then there is a high suspicion of malignancy. Then sun exposure also increases the risk of malignancy. And if there is a recent changes in the appearance of the lesion as described by the patient, then we have to think of a malignant lesion more. Then coming on to the clinical features of the different types of lesions which help us to diagnose what it is. First, we'll talk about the conjunctival nevus, which is the commonest type of pigmented lesion that we come across. So these represent almost 50% of the conjunctival pigmented lesions, and they constitute of diffuse infiltration of benign melanocytes, and they arise during the first or second decade of life, and limbus is the commonest site, and when it occurs at the limbus it's usually flat, and nevi appearing elsewhere like in the bulbar conjunctiva or the plica semilaris or the caruncle or the eyelid margin, and these lesions tend to be a little bit elevated. So characteristically, they have well circumscribed margins, and the pigmentation is variable. It can range from dark brown, light brown, and in 15% they can be amelanotic. And a characteristic feature is the presence of intralesional cysts. You can see the arrow is pointing towards one of those cysts, and they are present in 50% of or more of the conjunctival nevi, and it's a characteristic feature. And these cysts are not present in conjunctival melanomas. So these are the various appearances of conjunctival nevi. The first two pictures show this typical appearance. The third picture is a amelanotic one, and if you see the fourth picture, it's a nevus with very high vascularity. So even this nevi can have a variety of presentations. So these are not considered precancerous, but 5% of them can have a malignant potential. So follow-up is advisable for these patients. And secretion of mucin by the goblet cells in these inclusion cysts can cause a nevus to enlarge, and it can give a false impression of a malignant change. So you have to be aware of that. And mild enlargement and increased pigmentation can happen with hormonal influences such as during puberty or pregnancy. So how do we manage? They can be followed up every 6 to 12 months by using serial photography or detailed slit lamp drawings incorporating the dimensional measurements. And also the patients should be instructed to periodically inspect the lesion and note down any changes in the size, color, elevation or vascularization. And if there is a suspicious change or a growth, we suggest to do a excisional biopsy. And a biopsy can also be considered for pigmented lesions on the palpebral conjunctiva, on the cornea, fornix, because benign nevi are rare in these locations, especially if it occurs in a white person, elderly white person. So then if a lesion occurs at these sites, it's suspicious of melanoma, so a biopsy may be advisable. Then coming on to the second type of pigmented lesions, this is the complexion associated melanosis. It's also called the racial melanosis, and it's more commonly seen in individuals with dark complexions like us, but it occurs in persons of all races. So these are flat lesions and they are non-cystic, and they can range from light to dark brown in color, and they are bilateral and fairly symmetric. So bilaterality is a characteristic feature of this complexion associated melanosis. And they have irregular margins. They can increase in size with age, and sometimes they can cover the whole conjunctival surface. So the picture, I think all of our patients are having this kind of lesions. So pigmentation can involve the caruncle and palpebral conjunctiva as well, and it can extend into the cornea also as streaks or whorl-like pattern, which is called the striate melanokeratosis. And histology can show the hyperpigmentation of the conjunctival basal epithelial cells without any atypia or hyperplasia. And they are benign lesions with minimal or 0% risk of progression to melanoma. This is the appearance. So how do we manage? It's important to differentiate this condition from primary acquired melanosis, which I'm going to describe next. And some have recommended annual follow-up, but there is no malignant risk. But especially if it occurs in a white person, then it can be recommended to do an annual follow-up in these lesions. But in our country, almost all the people are having these lesions. So it has to be decided on a patient-based basis. So then coming to the primary acquired melanosis. So this is a little bit sinister lesion because it has a malignant potential. So they are acquired and non-cystic, flat, patchy or diffuse, tan to brown pigmentation of the conjunctival epithelium, and they are usually unilateral. And if bilateral, they are asymmetric, not unlike the complexion-associated melanosis. And they tend to be thinner than the nevi, and they are not well circumscribed like the nevi. And they are most often seen in individuals with fair skin. And changes in size of these PAM is seen associated with inflammation and as a result of hormonal influences like pregnancy. So this is the clinical appearance. You can see the features that I described. So most cases of primary acquired melanosis are actually benign, but a minority may develop cellular atypia. So there is a 30% risk of malignant transformation when moderate to severe cellular atypia is present. And there are certain factors associated with worse prognosis in these lesions. One is the larger size. So if there is less than 2 clock hours of conjunctival involvement, there is lower risk of malignant transformation. And worse prognosis seen in lesions larger than that. And if there is caruncular or fornicial or palpebral location, if there is progressive enlargement, if there is a nodular component, there is thickening and feeder vessels, then the prognosis is poor. There is a high likelihood of malignancy. So how do we manage these lesions? If there is involvement of more than 2 clock hours, it's an indication for an excision biopsy. So the lesion should be completely excised with the no-touch technique. And if there are diffuse lesions which cannot be dissected completely, they have suggested to use cryotherapy, topical MMC, and for the corneal component, alcohol-associated keratectomy. So, like I said, the cellular atypia is the most important finding in predicting the progression to melanoma. So once we do the excision biopsy and get the histology, if there is primary acquired melanosis without atypia, there is a little malignant potential, and they can be followed up by examination every 6 to 12 months. If there is SPAM with mild atypia, there is minimal risk of malignant transformation, and they should be followed up a little bit more closer. And if there is SPAM with moderate to severe atypia, there is 30% risk of progression to melanoma. So they need very aggressive follow-up. So then a small word about secondary conjunctival melanosis, which is also referred to as secondary acquired conjunctival melanosis, which is different from the primary acquired one. So it's similar in appearance. It can be unilateral or bilateral, and it's seen associated with certain conditions like systemic diseases like Addison's disease, previous radiation, pregnancy, trauma, and secondary to other conjunctival lesions like a squamous papilloma or a carcinoma. So history is important in identifying this secondary conjunctival melanosis, and also examination is also important to see any other related lesions. So then we come to the most important thing that we need to identify, that is the conjunctival malignant melanoma. So this accounts for 2% of ocular malignancies. It's rare in people like us, the black and Asian populations, but it's common in the white populations. It can arise from a primary acquired melanosis, like I said, in 70%, from a nevus in 5%, or they may arise de novo in 25%. So the overall mortality is 25%, and it's referred to as having a better prognosis than the cutaneous melanoma, but still it's a very dangerous lesion. So they are most commonly found in the bulbar conjunctiva or at the limbus. 25% can be amelanotic. They tend to have heavy vascularization, and they tend to grow in a nodular fashion and can invade the globe and the orbit as well. And they can metastatize into the regional lymph nodes, brain, lungs, liver, and bone. And poor prognosis is associated with location in the palpebral conjunctiva, caruncle, or fornix, invasion into deeper tissues, thickness more than 1.8 millimeters, involvement of the eyelid margin, pagetoid or full thickness intraepithelial spread, lymphatic invasion, and histologically having mixed cell type is also having poor prognosis. So this picture shows the various clinical appearances of conjunctival melanoma. If you see, you can see the highly vascularized nature and the irregular pigmentation. And if you see the third picture mentioned as C here, the lesion is very deep within the fornix. So if you don't do a very thorough examination, you might miss this lesion. So if you notice suspicious vascularity, make sure you look deep into the fornix as well. So how do we manage conjunctival melanomas? So ocular surface lesions suspicious of melanoma should be treated expeditiously with the complete white margin excision of 2 to 4 millimeters, and use this double freeze throw cryotherapy to the conjunctival margins, and the excision should be performed using the no-touch technique. And adjunctive treatments such as radiotherapy, topical chemotherapy with MMC can be used. And if orbital excentration is performed when a complete excision of the tumor is not possible, providing there is no distant metastasis. If distant metastasis is present, you have to undergo the chemotherapy, and all these lesions should be managed liaising with the oncologist. And here also prognosis consider the prognosis, there is high rate of recurrence of more than 50%, and metastasis at 15 years exceeds 35%, and they require lifelong close follow-up. And factors associated with poor prognosis include melanomas arising de novo, tumors that do not involve the limbus, and residual involvement at the surgical margin. So important things are complete examination of the ocular surface, including double eversion of the upper eyelid is essential in any patient with abnormal conjunctival pigmentation. And history is very important in differentiating between lesions. Incision biopsy is avoided in suspicious lesions to prevent seeding. But in extensive diffuse lesions which are suspicious, map biopsies can help to direct whether to proceed with complete excision. So if the lesion is very large, if it's suspicious, we can't excise the whole lesion, so we can do map biopsies, and if that becomes positive, then complete excision can be done. And no-touch technique, like I said, is important to prevent the tumor seeding. So this is a summary of what I said. So lastly, if I go back to the lesion that I showed initially, now I think you can diagnose this lesion. So it's showing the characteristic cystic lesions and well circumscribed, and it's more towards the conjunctival nevus. Thank you.